had gone. So I will officially get started with the webinar. Welcome this evening. Thank you for joining us to this webinar entitled Get Help and Hope, Access the Community Resources You Need. You see Sheila Armstrong in your webcam, and I am Janet McLean. I am the Education and Engagement Lead with Family Caregivers of BC, and Sheila is our presenter for tonight. So we're really thrilled that you can join us. This event is being recorded. Again, I'll just repeat that if you would like to go back and hear anything again or share it with other people, it will be posted on our website with this download. And so I'm just going to draw your attention right now. At the bottom of your screen, you'll see that it says Upload File. So this is actually a PDF of tonight's presentation. So you'll be able to download that as well. And once we have the recording on our website, we also post any handouts. So thank you for joining us. This is terrific. And just a few slides about Family Caregivers of BC. We are 100% dedicated to supporting family caregivers. We are funded primarily by the Ministry of Health for our provincial program. And I'll be talking a little bit more about that. We were the first provincial organization of our kind in Canada, so it's something we're very proud of. And we are getting busier and busier, which is a reflection of the caregiving job that everybody is doing. This is a busy slide, so I'm just going to suggest that you go to our website, because basically most of what we offer you can find on our website. I am just going to give you a little bit of an overview though. So caregiver support is one of our key pillars, and our main ways of supporting you is through our toll-free line province-wide. We're not a crisis line, but we are open Monday through Friday, 8:30 till 4 every day. So you'll see the toll-free number on this slide at 1-877-520-3267. If you call that number, we will help you with anything that you're going through. So whether it be just trying to understand where to go next, accessing resources, looking for a caregiver support group, or maybe just talking to us about what's going on for you. We are here to help. And what we'll do is we'll listen, and then we'll direct you to other resources. And one of the things that we make a point of doing is connecting you to resources in your local community as well. So while we're provincial and we have resources on our website and webinars like this, we totally partner with community-based organizations to make sure that you get face-to-face help in your community if that's possible. So I've talked about our caregiver support line. We have one-to-one caregiver coaching for really difficult caregiver issues. And then we have support groups. We don't run all the support groups in BC, but what we do is we support volunteers to establish the support groups. So we offer training and content support for support group facilitators across the province. And I mentioned that we have an extensive online resource center on our website, so would welcome you to go on there and have a look at what might appeal to you. In terms of our education, we do webinars and workshops such as the one we're doing tonight. We're developing some new materials for our website that we're hoping to launch this year. And we do a lot of events and presentations. Last but not least, we do caregiver collaboration and engagement with the health sector. So if you're someone who feels that you might be able to add your voice as a caregiver to health planning, health system planning and delivery, please by all means get in touch with us, and that can be from anywhere in the province. We are always looking for caregivers to be involved at different tables and help us out with things like focus groups and reviewing documents. So it's a huge help, and it's a big part of what we do. If you haven't been involved in a webinar before, just going to run over some norms for you. When you signed in, we promised to keep your confidentiality, and so we won't share anything that you don't share. And as I mentioned before, the way to share is just to type in the chat box over in the left-hand corner, the left-hand side of your screen. I just typed in. You should be able to see that. For all of you who are participating, you have the right to take part or not. some people like to chat, others just like to listen, and whatever you're comfortable with is great for us. And we welcome your feedback and input. If you have any comments or questions, I'm going to be watching the chat box. Sheila's going to be presenting, but we'll make sure that we don't miss anything that you're bringing forward. And I'll do my best to make sure that we have equal time for everybody to get their points across. And just a word of, that not everything that others say might be your own experience, but it's an opportunity for you to reflect on how that might be for that other person, and if it does apply for you. So that's the value. I love the webinars for their live aspect. It's really an interesting part of the webinar. So Sheila, who you see in your screen, Sheila is a retired RN and has an extensive background in nursing across the care continuum. So when we say that, we mean everything from community into acute care and facility-based care. And Sheila practiced nursing from the whole person perspective. So she understands that caregivers just aren't physical. It includes their mental and emotional well-being. So that's a lot of, a holistic perspective on nursing. So Sheila's going to talk to us tonight about how to know when you might need resources and how to find them. And Sheila had previously worked at Island Health and was very involved in all kinds of different services and referrals. So we're thrilled to have her here. And Sheila, also you were from back east.
Yes.
Yeah, her origins were in Ontario. Mm-hmm. So she's got cross-Canada experience as well. So we're just absolutely thrilled to have Sheila presenting for us tonight. So I'm going to turn it over to you, Sheila, over to you.
Good evening. This is a little bit different. I'm not used to being seen on screen, so I'm not happy with that, but nevertheless.
You'll forget it once you get into it.
I'll get going. So our learning objectives for this evening our objectives are to understand what community resources exist based on where anybody is in the province and where you are in your caregiving journey. We hope to gain an understanding of how to access these community resources, not always an easy task, and to understand the importance of support in your caregiving role. It is very, very, very important. I was just reading something yesterday, part of my learning in this role as well, as to try to instill confidence in people in their the part of the journey that they're on, that they have some help and are able to understand what resources are available and how important their role is and how to access those resources to move forward in that role. So that makes it a little bit easier for everyone concerned. And to learn about family caregivers of BC, the services that can direct you to the resources that hopefully are of value to you. So those are our 4 learning objectives for this evening. I hope that when we get to the end of the presentation, that you will have that knowledge. If there are any questions at any time, please type them in the chat box there, and we will answer them as best we can. So first of all, I'd really like to get some sense of where people are in that caregiving journey. So I'm just going to give you a few moments to, to perhaps go into the chat box if you feel comfortable doing that, and letting us know where you are in your journey. And it may help us to provide relevant information.
So when you say that, Sheila, you mean where are they in terms of early stage or middle stage or late stage? Yeah. Because each stage is really different. So yeah, it would be really helpful to know where some of you folks are and how we can best direct.
Yeah, and we are going to talk about how to access in the early stage from community, how to, sometimes that early access is from acute care. We're going to talk about that as we go along, but it would really help me to provide the information and help you with resources if I have some sense of where people are.
Right. So it looks like we've got someone
So
at
for those
early.
of us that don't have access on the computer, can you hear our questions?
I can hear you, yes, loud and clear. So.
Okay, excellent. Thank you.
Yeah. So yeah, it looks like a lot of middle stage and early stage. Yeah. Okay.
And my role is a facilitator with the Alzheimer's Society and for caregivers, and so I'm joining this so that I can get more information on how they can access resources for their needs.
Oh, welcome. That's just great. Yeah, excellent. About a third of our calls are from people caring for someone with dementia.
Yeah.
So it's just a huge area, isn't it? Wow. All right. So we've got
Early and middle.
Yeah, early and middle. It looks like not very many at the late stage, but yeah.
Good. Excellent. Okay.
All right. So we've got that, and here we go.
So the caregiving situations as we see them, and certainly this is what I have come across so far in my journey through this support role, is that there are people who are new to the caregiving situation, and in a lot of cases just don't know what we don't know, and it can be very overwhelming. Getting lots of information, trying to sort through it, and trying to sort out who is who in the whole picture. I'll get into that a little bit more as we go through the following slides. And sometimes you may be directed to community services or not, and that can be a little frustrating too. There are those who are coping in the community, so you're managing. Some days are good, some days aren't, or the care recipient, some days are good, some days aren't so good, but somehow you're managing. You, the caregiver, are managing. The care recipient sees members of the healthcare team when they're required, but they may have dropped off that community service roster. So you're kind of alone out there coping, but not with a lot of support and not knowing where to go and how to access support. Then the next stage, where the care recipient, the loved one that you're looking after, requires more intensive care, and they have more care needs, and these episodes and increasing needs are becoming more and more frequent and more overwhelming. It could be appointments and treatments and medications and personal care, and there you are. You don't know quite where to go, who to talk to, or what to do. And then you get to the point a little bit later in the caregiving situation where whoever you are, whoever you're looking after, their condition is really declining. And sometimes that's a slow decline, but often it becomes a rapid decline, and the care needs become very intense. And then at the very end, or toward the end, we're looking at palliative or end-of-life care. And that care has transformed to comfort and quality of life. It would appear from what we have received here this evening that we may not have anybody at that stage yet. It looks to me as if we might have in that new coping in community, maybe a little bit into the next navigating episodes. But I haven't seen anything yet about the decline in the palliative or end of life. So I will be focusing on those first three as we go through the next little while. But if anybody does need more information about more toward the end of your caregiving stage, then please let us know, and I can certainly address that as we go along.
Absolutely.
So our map of community services, don't quite know where to start, but I would say let's start up on the left-hand corner there, where healthcare provider care team. That is usually, let's start, sorry. I've lost my notes. I had them on a slide and I can't access them, so sorry, just give me a moment here.
The best laid plans.
Yeah, best laid plans. We just couldn't get my computer into the system here. Couldn't attach to the Wi-Fi. So if someone is attached to the health authority, for instance, either at the early stage or middle stage or at the end stage. So that's usually where you're up on the right-hand side, where you got the Ministry of Health and Ministry and Health Authority support. That's where at the initial stage, often, but not always, you will find yourself where you have someone you're looking after. They require care, you contact the appropriate people, get them attached to the health authority, assessments go on, and then home supports are set up. And that's the next one on the right there, personal support. That can be involved at any stage, but we really, really hope that for caregivers it's in the early stages so that it helps ease some of this burden of caregiving. The community support, they can be involved at any stage, but again, we kind of hope that happens at an earlier stage. And then the healthcare provider care team, that's, it often is, it can be certainly at the beginning, but more often, more intense towards when the condition starts to decline and you're getting more toward the declining stage or the end stage. So those little circles in the middle, they can twirl around a little bit. They can go to any stage. You can just, if that was on a little twirly thing and we could twirl it, you could make them go to any one of those. We can make community supports go under that could be involved at any stage, especially for caregivers, the earlier the better. Or we could move it way up there to the healthcare provider care team at an early stage. That can happen too. So that blue circle can turn around and hit on any one of those community services at any given time in the journey. But as it sits right now, that's where you kind of liked it to be. The community supports and personal supports in the earlier stages. Certainly the health authority supports, I do always say to people, if your loved one is not known to the health authority, make that call and see if you can access them, get them into the system so that help is there when it is needed.
So if we just use an example, and I'll just throw, and I welcome any of you to type into the chat box with your own personal examples, but if we were to use the example of someone who has been diagnosed with maybe COPD, and so in that example, if it's an early diagnosis, going to the slide that Sheila's got here, you would probably, as the caregiver, be connected through the patient to the healthcare provider care team. So that would be your family doctor, hopefully, or a family doctor practice that you're attached to. And maybe some specialists, because you may have gone to a clinic or had some tests done, and maybe you've had to go and see a respiratory specialist for a diagnosis or whatever. And so as Sheila said, at that point, you may become informed about what community services are or what's available in the community, but some of the calls we get, people go through this initial diagnosis and they may get some connections, but then life goes on and things kind of stabilize and the person they're caring for, gets into a pattern. Hopefully they're coping fairly well. So then they tend to maybe loosen the threads with those community resources, like they're not receiving home support in the home anymore because they've kind of gotten themselves organized and they're coping. But then, things keep going along and they get to a different stage in the caregiving journey and things heat up again. And so, Sheila, what would be your advice? Like, we get a lot of calls of people in that situation and they're no longer attached to anything.
Yeah, if someone has already been on care with the health, any of the 5 health authorities, so within any of the health authorities in the province, and yes, if it's kind of gotten to a point where they're not requiring that service anymore, very often their file will be closed. They used to keep them open for a length of time, a specific length of time, and then close. They would make another call to see if people needed that service in their service anymore, and if not, they would close the file out. So if that has happened, it's just a call again to the health authority, to the GEL line, or the General Inquiries line, and make that referral again. And it's very, if you tell them that that person has been on service before, they can probably pull up that file somewhere in their system, if it hasn't been too long ago, and reactivate the file and make that referral to case management again, or to the whatever service is needed at that particular time. But more than likely it would be to case management. It could be to home nursing care, it could be to the respiratory therapist, it could be to the dietitian, it could be to the one of the either physiotherapist or occupational therapist, depending on what the need might be.
Right.
But it is simply a call again to the health authority, to the General Inquiries line. We do have a slide with those numbers for you, which is coming up in a little while.
Okay, but that's good advice, I think,
Yeah.
because people don't tend to think about that.
Yeah.
And then they feel really lost and alone.
Yeah.
So, yeah.
Again, anyone can make that referral. We'll be talking about that as well. Anyone can. Sometimes the family physician, if they see that things are going a little awry and they speak to their client, their patient, they will make that referral to the health authority as well. And we do have special lines in some of the health authorities. They actually have a line that they call, and there are people who are connected to physician practices for their patients. So but the health authority it's really important to, if people aren't connected to the health authority, to connect with them. Now, not everybody might at any given point, particularly maybe in the earlier stages of the care, their journey, might, if you made a call, they might say, well, no, you don't, you might not be eligible for the service. But that is very rare. Usually when people have an illness and it has been identified, there should be no problem in accessing service. However, there has to be a need, and that is determined in that call to the General Inquiries line. But I think it's really important to make that call and see what transpires from there. Now, we will be talking a little bit later about the personal supports and how one can access those and when and all that sort of stuff. But do remember that the healthcare provider care team is a real resource as well. So if you're kind of muddling through and not knowing where to go, by all means, speak to the GP, either your doctor or your care recipient's doctor, the clinic, the nurse practitioner, the nurse in the office, whoever is involved with the care, and let them know that you need some assistance. And of course, we're always available to help you too through this journey and with resources and at any given time. So the healthcare provider team, this can be the general practitioner, family doctor, or clinic, if you don't have, and so many people in the province now do not have a family physician, but may attend a walk-in clinic. The healthcare professionals involved might be RNs, it might be nurse practitioners, it might be therapists, dietitians. They could be your specialists, as Janet noted. It could be gerontologist, for instance, or it could be a psychologist or a psychiatrist, or it could be a surgeon, someone needing some help following some surgery. If one is in hospital, usually attached to acute care liaison staff. The liaison staff are the folk who provide that service that home and community care case managers provide in the community. So we call them liaison case managers. They are the ones who work out of the hospitals, the acute care staff. And in the community, they're home and community care case managers. They may be changing their title one of these days, but that's what they are right at the moment.
Right.
And then, of course, we have our hospice staff at end of life. So that's pretty much your healthcare provider care team. Could be more, but those are what we can think of right at the moment. Some of the supports that the Ministry of Health has is HealthLink BC. The link to that is there. You can call 811 toll-free to speak with a qualified health service navigator, a nurse or dietitian, pharmacist, or exercise professional about your health concerns. And they do have translation services that are provided for more than 130 languages. So it's a good resource to link into. The BC Seniors Guide is excellent. If you haven't seen one, if you can get your hands on one, they're really, really good.
I think it's online as well.
I think it's a PDF online, yeah. So you can go online and look it up. So they have resources information. They're provided on living healthy lifestyle and community resources. It's excellent. It's been around for quite a number of years. In fact, we just uncovered one in our laundry room at home from way back when. We were kind of chuckling about it, but it's still, a lot of the information is still quite pertinent. But the websites are there, the English version, and then the website for the Chinese version and the Punjabi version.
Right.
So excellent resources from the ministry, through the Ministry of Health. I see a question.
Oh, right. So,
okay,
well, thanks, Repeat. We hope we're a valuable community resource. We do our best, and we do a lot of that by collaborating with local community organizations. So, we're not trying to cover all the ground. We very much provide that navigation and referral service. So then we've got this question, what about First Nations Health Authority? Should they be contacted first or in conjunction with the local health authority?
The First Nation Health Authority is, my understanding of the First Nation Health Authority are, yes, I would think that they would be in first. And if they work in conjunction with the local health authority, then whoever you contact in the First Nations Health Authority more than likely would be in contact with someone through their home and community care program if that's what would be needed. But yes, I would say contact the First Nations Health Authority first.
So then they would connect with those
I would
other
think that they would.
Okay.
That has been my experience, and I know that I have dealt with the First Nations Health Authority for our First Nations folks.
Right.
They have all of the
They would have all
they
the
have all the
contact,
contacts. They
Right.
have all the ability to set up whatever is needed, and if they need to contact the local health authority, they will.
Mm-hmm.
Yeah. So the health authority. No, is that you?
Oh, yes.
You're welcome.
Thank you. Yes.
You're very welcome. The health authority supports, publicly subsidized. We have home and community care, and the services that are provided are the home support, respite services, adult day programs, respite in home or facility-based respite, subsidized assisted living, subsidized residential care, and palliative care. So those are the publicly subsidized services that the health authorities support.
Right, and the key there being subsidized.
Yes. So these are the telephone numbers for the 5 health authorities within British Columbia for their general inquiry lines. Now these are the lines that you would, as a caregiver, would call if you were making a referral for case management, or if you had someone at home and perhaps they had been in hospital and as a result of some event, let's just say a stroke, for instance, because that's the one that just comes to mind, and usually the one that requires some adaptation for when they go home. So equipment, or maybe a little adaptation to the bathroom, or whatever is needed. And if that occurs, then the referral, the referral, more than likely in hospital, will be made by the liaison case manager. However, if it wasn't, then you could call whichever health authority you live in, could call the general inquiries line and say, my loved one has had this event happen. We have been told that we need certain equipment. I don't know what that is, but I need help in determining how to make my home safe and accessible for my loved one. And then they would then make that referral, take the information from you, make that referral to occupational therapist. Yes.
Was there a question from the phone? Maybe not. Maybe we just caught someone without their phone muted.
So the general inquiry line, yes?
I wasn't trying to get through to you, but since we have a half a second, there's a lot of information that you're giving, obviously, that's on your PowerPoint. You're talking about phone numbers and all this different information. Because I'm on the phone and I have no access to any of that information, can I find that information from your PowerPoint after the fact so that I have this information available to me?
Yeah, you bet. So it will be posted on our website with the recording of the webinar. So try that next week. Go onto our website and look for FCBC webinars under our resources tab, and you will see the listing for this webinar. The recording will be there as well as the handout.
Okay, thank you.
Yep.
So referrals go through the general inquiries line, and those numbers are listed there for each health authority. I will say that that can be a little frustrating as well. So just be aware that sometimes those lines are extremely busy.
Right.
And again, we only have X number of people answering the phones at any of these offices, the general inquiries line offices. And sometimes you will have to leave a message and they will get back to you. I know it can be frustrating, and just be patient. If you didn't hear back within 24 to 48 hours, call again. But I understand. I've worked in that office, with the general inquiries line folk, and I know that it can be very frustrating from both sides. But we used to hear lots of people say, oh golly, I called and I didn't hear anything back, and I had to leave a message and I had to call back again. Mm-hmm. Yeah, it happens, unfortunately, but they try very, very hard to return their calls within a timely manner. But if you feel that it needs to be, within 24 to 48, if you haven't heard, do give them a call again, but be patient. The health authority support, it usually starts with a call to the general inquiries line. So this is your person in the community in the early stage, or maybe in the middle stage too. Maybe you've been coping okay, but all of a sudden you feel, I need some help, and my loved one needs more help than I can possibly give them at this time. And you have to recognize that caregivers are busy people too. And sometimes their caregivers are in that sandwich generation where you have children younger who you're looking and providing for, and your own life to lead, sometimes working full-time or part-time, whatever it is, or not. And then you have your caregiver, you being sandwiched in between, your care recipients, or you being sandwiched in the between. You're the one in the middle, someone younger you're providing care for, and then someone older you're providing care for, or it could be a spouse as well, and kind of sandwiched in there. And you suddenly realize that you need some help. You may have spoken to the family physician, either your loved one's family physician or your own physician. They may have made that referral for you, or you can make that referral yourself. And again, I do recommend that you make that call to the health authority and ask for case management assessment for your loved one. They will ask a lot of questions of you when you call, so it often is best to make that call when you're with your loved one, whoever it is you're providing care for. And the care recipient has to be in agreement with that call to the health authority, because when the case manager calls, if the client says, the person says, I don't need any help and I don't want any help, they can't proceed unless they have the permission and agreement from the care recipients that they want them to come. So it starts with that conversation with your loved one first. It has to be a collaborative effort.
And what kinds of questions would they generally get asked when they call the line?
First of all, they'll ask personal information like date of birth, medical health record number, address, and all that sort of stuff. General stuff that you normally would be asked no matter where you went as an intake.
Right.
And then they'll ask some basic questions about what's happening, about the perhaps a diagnosis, whatever the condition might be. And then they'll also ask a bit about care needs and what you're providing, what you're not providing, that sort of thing. So it's best to have all of the information that you want to relay to the health authority about the care recipient. Have little notes so that you can remember everything that you want to tell them. And I just recently was talking to someone about their loved one, and they were going to be calling the health authority, and the person has dementia and was going out and getting lost in the community and having to be brought back home. They were also leaving pots on the stove. This is very common, leaving pots on the stove, burning pots, not dressing themselves, not feeding them, not eating, even though the food might be there, they're not eating it, they're not taking their medication properly, or they're dropping it all over the floor. They're not bathing, they dress inappropriately for the weather, for the types of weather conditions. So those kinds of things, it's really important to relay that kind of information, because that indicates that this person is not safe at home without some help. And they will ask about how much care you're probably providing, or anybody else who is involved with the care, how much is being able to be provided, and all that sort of stuff. So you have to be very honest with them, and be very forthright, and not forget all the important things that you should be telling them, because if you don't tell them everything, and sometimes we forget, like you forget that, oh yeah, golly, Mom went out last week 3 times and got lost and couldn't find her way home. But someone brought her home, or heaven forbid, sometimes the police bring them home. But you forget those sort of things because it sort of is the norm. It becomes the norm, and you kind of just don't think that that's something you should be relaying. It is. It's very, very important. So all those kinds of things. Mm-hmm. So the case managers, so what happens is with the assessment is of the care recipient, you do need a case manager, and this is through the Home and Community Care Program. So when you call the General Inquiries line, you're asking for a case management assessment for home and community care. And the case managers, well, the Home and Community Care Program supports people in their home with either acute or chronic diseases, illnesses, physical disability, and it is done to help them remain at home and live as independently as possible. Case managers assess the care recipient for whatever their needs might be, and these are usually for personal care needs. These are for personal care needs. Unfortunately, at this present time, home and community care cannot provide service for housekeeping, outside work, some of the meal preparation, actual meal preparation. But they do provide the service for personal care needs like bathing and showering, dressing, medication management, anything that is showering, bathing. They do, in a lot of cases, provide help for simple meal preparation, and that usually is pre-prepared meals that might be frozen so that the care worker can take them out, eat them up, and have them ready for someone to have as their meal. They can do that while they're in the home, perhaps providing other care for the person. And it does vary. I will say that it does vary from area to area, from health authority to health authority. Some of the bigger centers where they might be able to provide a little bit more service than some of our more rural areas where it's much more difficult, where the care workers are scarcer, and services are perhaps not as, the service to be provided is not as great as it is in some of our more urban areas. But home support services are available. I know here on the Outer Gulf Islands, there's not a whole lot of service that is available to, even for personal care needs, to people in their homes. It's just because there aren't enough home support workers working on the island to provide that. And that is true in some of our very rural areas, in our northern areas too. So, they provide as best they can. So it's not equal all the way around this province, but they do the best that we can do to provide the service to keep people in their home. Because you will hear from the health authorities that home is best. And in most cases, that is quite true, as long as we can provide that care that is needed to keep people safe and healthy in their homes. The home support services, as I said earlier, in the home are delivered by quite a number of professional people. They could be the case managers, and the case managers can be now across the province, who could be RN case managers, they could be nurse case managers, they could be social work case managers. Our therapists, our physiotherapists and occupational therapists are also case managers and can put the home support service in the same as the case managers, the RN case managers and social work case managers have always been able to do. But now everyone is in that role and can provide that service. So depending on what it is that anyone needs, it could be an RN coming out as a case manager, it could be a social work case manager, it could be a therapist coming out and doing that initial assessment. Now if, let's say an RN came to the home and assessed your loved one for needs and services to provide appropriate services, but in them, while they were there, recognized that there might be a need for, say, a dietitian, might need some help because the person is failing. They're failing to thrive because they're not eating, their diet is not particularly good. Maybe they have some identified allergies or insensitivities, etc., and might need a program set up for them, a dietary program set up for them, that case manager would more than likely make a referral to a dietitian from the local office to come and make an appointment and come and see that care recipient to do an assessment of their home from the diet perspective, from the nutrition perspective. Or they might recognize that some equipment was needed in the home, maybe some modifications needed to be made, and grab bars, for instance, needed to be added, or things like that. They might then make a referral to the occupational therapist to come and do a safety assessment, home safety assessment for your loved one. So they make those referrals usually often at the time of that initial assessment, but that referral can happen anytime throughout the time with the health authority. It can happen at any time.
So Sheila, if a case manager comes into the home and they do an assessment and then they come up with a care plan for the care recipient, can the caregiver ask to see that care plan?
That care plan is actually in the home. Excuse me.
Okay.
The care plan, at least here, so I'm speaking for Island Health. I shouldn't assume, but I would suspect that in every health authority, they manage their care for their care workers in the same way. So here in Island Health, when a case manager has been in and prepares a care plan, it is sent either to the health authority, to the RN supervisors in the health authority, or to our contracted agency here in the South Island.
Right.
And they prepare a booklet and write up the care plan. They write up if medications have to be given. There are certain procedures and things, ways of giving that, and the papers are all put in a binder or a folder, and that folder with the care plan stays in the home. And I know here in Island Health, it is usually kept on top of the refrigerator. It's always in the same place, so that whoever is coming into the home can have a look at that. There's nothing secret in it, but that care plan, yes. However, can't write in that. The only people who can write in that legitimately are the care workers who sign the sheets when they can do their task or give the medication, or any changes that are done, the case manager or the RN supervisor for the home support may make some notations in there. There are notes written in there sometimes, just that they have done certain things, and they write them in there. If the family wants to talk to the case manager about the care plan, if they see something that they feel maybe needs to be updated or added to it, it's just a phone call to the case manager to call and have a chat.
So your advice to the caregiver would be look at that care plan.
Yeah,
because that is what's going to what the plan is for their care recipient, and that helps them understand the process, and like you say, if they have any concerns or questions, then they're in a better spot.
Yeah. So, yes, and if you see something, if you as a caregiver see something that you feel is missing, by all means, contact the case manager and have a little chat. Liaison staff in the hospital, they assess the care the same as the case manager in the community would do. They assess the care needs upon discharge from acute care. They will make appropriate referrals to the community for whatever needs might be. They usually, if prescriptions are needed, they will look after all of that as well. They will see that the doctor signs off on the discharge medication list, and either give it to the caregiver, or they will have it sent to the pharmacy. If someone has a particular pharmacy they're using, it will be sent to that pharmacy to be filled and be able to be picked up by the caregiver. So then there's a little box there at the bottom. It says what the personal care needs are. So it's bathing, eating, meds, dressing, hygiene, and toileting. That's pretty much what is provided through the home support, through any of the health authorities. So just remember that it is personal care, which someone will at some point will refer to as activities of daily living, or ADLs. And the other things that caregivers do that are and they're burdened with are they go into appointments, transportation, housekeeping, laundry, making meals, all those things, the financial, having to look after all those things. Those are called instrumental activities of daily living. And unfortunately, caregivers do have to provide those. The health authorities, the caregivers are not allowed to do any of those activities through the health authorities. So just keep in mind that no matter what is happening in this process, you've made the referral, the case manager comes, you see all these people coming in and out of the home, you as the caregiver need to be consulted and included in the consideration of all of the service or any of the services being provided. You are an integral part of that whole piece. So if the case manager, whoever it might be, is coming to see your loved one, you should be there. Just because it is really important that you be part of it, but also it's very overwhelming for people. You know yourself how overwhelming this unknown piece is. So imagine your loved one who might be elderly, not feeling very well, someone coming in and rattling off a whole lot of stuff they don't understand and they hear it all, but they may only grasp a little bit of what's being said. And it's really important that someone else is there to hear what's being said, to be asked, and you would be, as a caregiver, be asked, hopefully anyway, be asked for your input into some things that are happening.
That's a really good point. Sherry has asked what the role of social workers are in all of this.
Well, the social work case managers do the same assessments as the RN case managers. However, social work folk can sometimes deal with, they do deal with other issues as well. Sometimes it's housing, sometimes it's financial, all the things that, sometimes it's just listening too, that they do in their role. But basically they're doing the same thing as the RN case managers, except that the RN case managers, the registered nurses, they do carry what we call the delegation of tasks, and those have to do with medication management. Social work case managers cannot write up the delegation of tasks. So if there's a medication issue that arises, they have to put that off to usually the home care nurses, who will carry those delegations of tasks and set those up for the client. Because medication management is quite a large piece of what a service that is provided to our care recipients. Social work deal with, I'm not exactly sure all the things that social work deal with, but they behaviors. We've often had our social workers go in and deal with people who have behavioral issues, and often the behavioral issues are often mental health issues, not necessarily severe mental health issues, but it could be depression or anxiety, that sort of thing. So sometimes we make a referral to our social work. The social work case managers will see their own clients. Let me be clear on this. They do not see somebody else's client who may have an issue that needs social work. There are also social workers who work within each health unit, who case managers, RN case managers or therapists might refer to social work to help with through some issues. A lot of it's financial. I will say a lot of the referrals that we made to social work had to do with financial issues. Some were behaviors. The social work case managers, of course, would deal with all of those issues for their own caseload. Home and community care is a little bit odd because we have these different people working in different roles. But the social work case managers do all of the social work stuff for their clients, plus the case management, except for whatever might have to be looked after by the nursing staff. If it's a nursing issue, they then have to refer to home nursing care.
I hope that answers your question, Sherry, but if you have further questions about that, you can, oh, good, okay. Excellent. So you want to move to the next one?
Yeah, I just wanted to talk just very briefly about the adult day programs, the home support. The home support programs are they're provided in various ways all across the province. Some are in-house here at Island Health, part of the Island, Centre Island, North Island. They're in-house, so that Island Health provides that support in the home and in our assisted living buildings. In the South Island, it is through a contracted agency. Other parts of the province, same thing. It could be in-house, it could be through contracted agency. So the home support staff come in, the case manager sets up a care plan, they send it to the home support supervisor, or whoever that might be, and then the care plan gets sent into the home. The care workers are sent into the home. They are advised of what the care plan is, and they provide that service in the home. Adult day programs, we referred to them a little bit earlier on. Again, those are the subsidized adult day programs are accessed through case management. Usually 1 day a week, sometimes 2 days a week. Usually waiting lists for them, often very long waiting lists to get into the adult day programs. And I will say that the adult day program is not for everyone. It very much depends on the client and what the program is offering to and whether it meets the needs of that client or not. So some people go and they have a wonderful time. Other people say, I'm not going to go there at all, thank you very much. Some people go and say, I'm not going back. And some people would love to go 5 days a week. So it very much depends. But a wonderful service for those to whom it provides the appropriate service. I just want to remind you that anyone, absolutely anyone, can make a referral to home and community care by calling the gel line.
And we will have time for questions at the end, so I hope for any of you that may have different experiences or you're thinking about it, you'll have the opportunity to chime in later. So
I just want to very briefly talk about the liaison staff and accessing care when they're discharged from acute care. Oftentimes when people go home from hospital, they're told to go and see their family physician within a week or 2 weeks or something like that. And if your care recipient does not have a family physician, I just want to emphasize that if you have or your loved one has gone to a walk-in clinic more than once, the same clinic more than one time, there will be a record and that of their what they've been there for in that clinic, and that clinic is obligated to provide that care for your loved one upon discharge from hospital. So what will happen is the hospital, you will contact the clinic and tell them that your loved one has been in the hospital, that they're being discharged, let's say tomorrow, they're being discharged tomorrow, and you would then ask the clinic to contact the hospital, request a copy of the discharge information to be sent to the clinic for follow-up, and then make an appointment with the clinic for your loved one to ensure that that follow-up happens. Okay, so the clinic is obligated, if you've been there more than one time, 2 or 3 times if you've been there, or your loved one's been there, to provide that care, even if you don't have a family physician. If special equipment is required, the liaison staff, they will make that referral to home and community care to the therapist to come into the home. The therapist would then call you or your loved one and make that appointment at an appropriate time.
That's good advice. Yeah.
Yeah, and if special equipment is required, the liaison usually will make that referral. If they don't, you can then call home and community care yourself and say, your loved one's being discharged from hospital, I need to have someone come and do a home safety assessment, and for equipment that might be needed. So, one of 2 ways to get. And if equipment is required on a short-term basis, if your community has a loan cupboard, you can contact that loan cupboard and obtain that equipment. Usually it's about for 3 months. Through the Red Cross, it's I think free. If not, it's a very minimal charge, and that allows time to have someone go home, have that assessment done, see how they do at home, and then determine what equipment actually is needed before you go out and buy a whole lot of stuff that might not be needed. But just check with your community, see if there is a community loan cupboard before you go and buy anything.
Yep.
Yeah. Okay.
All right.
Yeah, so the health authority also provides, now this is when we're getting on to that late middle stage there, where someone living in community, you're providing care, however, it's becoming quite a struggle. They may need more, and they may need more care than the health authority is actually able to provide. And I don't mean because of the intensity of the care, it just may be that hour-wise, they're not able to provide enough people to go in 3 or 4 times a day to provide that care. Your care case manager then might say, well, have you thought of, and they can look at perhaps assisted living. And it is subsidized service through the health authorities. There are certainly eligibility criteria for assisted living. And if they're beyond that eligibility criteria for assisted living, then your case manager might be then talking about the higher level of care, which is residential care. So those do happen. I'm not going to talk about assisted living or res care and the eligibilities because they do, although they are, assisted living is, each assisted living facility or building is registered with the Office of the Registrar for Assisted Living, and there are guidelines. There's legislation and then the guidelines for the health authorities to follow. They do vary a little bit from place to place. So I'm not going to go into them, but basically people moving to or looking at assisted living have to be cognitively intact. So they have, their cognition has to be good. Early dementia, they still might, their cognition still might be good enough to access assisted living. They have to have care needs, daily care needs, hands-on care needs, personal care needs. They may be living in a situation at home that might not be safe for them to live in, or might not be able to access. So some people say living in a home that has 3 or 4 stories with many, many stairs, and they've had something happen, and they're not able to access their home anymore, you might be looking at something like assisted living if all the other pieces fall into place for them. So there are those two services that are available, subsidized through the health authorities: assisted living and then residential care. Residential care, just think of it as someone needing 24-hour professional oversight.
Right.
And sometimes very high care needs that preclude them from assisted living, because they have to be safe, and if they can't provide that level of care in the assisted living setting, then we have to then look at a higher level of care. So there are parameters around those. You can actually look that up, the Ministry of Health, on their pages. Just type in the Ministry of Health and look under the various care, assisted living and residential care, and it's the overview for both of them is there, and it's easy to read.
Yeah.
The cost for the health care subsidy, it depends on the finances of the individual care recipient. So when a case manager comes to the home, whichever case manager it might be, comes to the home, they will perform a financial assessment. And what they need, the piece that you as the caregiver should have at hand, is the most recent notice of assessment from Revenue Canada. And they will do an assessment for the cost for home support service. In some cases it is zero, depending. It's a per diem rate, so it's a daily rate. So it could be assessed at $10 a day, and your loved one might get 4 visits a day, but it's still just $10 for the day. The home support rate is per diem. The assisted living and residential care rates are monthly rates, and just have the notice of assessment available when the case manager comes to the home. And again, very important that you, the caregiver, need to be consulted and included in the consideration of any service that's being provided to your loved one. It is very, very important. You are often, most of the time, you're the advocate for your loved one, or whoever it is that it could be a very good friend, whoever you're providing care for. You're their advocate, and we all need the advocate. We need to be able to wind our way through these systems, and it's not easy. And even those of us who have worked in this system for years and years and years still struggle at times to find our way through it. Mm-hmm. It's really important to know the questions that you want to ask and who you ask the questions of.
Yeah.
And the next one. So some of the community supports, we've just listed a very few. The nonprofit organizations, Better at Home, in the communities that they do service, you'd have to go and look, just Google it or whatever browser you use, just type in Better at Home and see if they provide service in your community or anywhere near your community. Disease-specific organizations, let me think, the Alzheimer's Society, the MS Society, the Diabetes, Heart and Stroke, all of these different things. So whatever the disease might be, you can then find those services in your community or near to your community. And then the seniors organizations. And I would say, look at the senior clubs that you have. Look at the recreation, community recreation services. Look at if you have silver threads in your community, those types of things. And the easiest way is to if you have access to a computer, let your fingers do all of that, because I sit at home sometimes or in the office when I'm taking phone calls and I'm sitting there on the computer and just looking some of these up for people. Yeah, you have that available in your community. I can get that to them really fast. It's real easy. Mm-hmm. So you can look them up yourself. Sometimes there are guides, seniors guides, communities put them out. I think I have 2 or 3 right now. I have one here from, put out here on Southern Vancouver Island. I know there's one up in
Partial
Qualicum.
There's one in Surrey, because I just got a copy on the weekend when I was over there. So, you know, look in your community, as Sheila said, and do that Google and just see what you can find. Just putting in community supports, you know.
Or seniors resource guide or something like that, and they're putting them all up on PDFs now, and they're wonderful resources. Those booklets have tons of information in them, tons and tons and tons of information, very valuable information.
And so when Sheila was mentioning previously about instrumental activities of daily living, so these are the things that the health authority will not provide. So you can't expect when someone comes into your home and does an assessment, your subsidized services will not cover things like housekeeping, grocery shopping, not normally meal preparation, or help with transportation, or, you know, those are the things that some of these community organizations can really help with. You know, there might be a nominal charge, or, you know, some of them even have volunteers that do this work. The Better at Home program is a good example. It's a United Way funded organization that has branches across the province, and they will do some of those things, those instrumental activities of daily living. I don't know if there's a charge for clients, but, you know, I think it's minimal. I think they try to keep it really minimal. So if you feel like you're alone and you're feeling overwhelmed, you really do need to reach out, and because there's often supports out there that you might be missing out on.
Even some of the service organizations provide help to people. It's amazing where you can find help. It really is.
Like the Lions or Rotary, or you know, some of those clubs.
Kiwanis.
Kiwanis for sure.
Yeah, they will provide service. Look to your volunteers. There are lots of, most places have volunteer services. Also, if I may, I know that if someone is involved with a church organization, there are people within the church who provide friendly visits. There are people who will drive people to appointments. There are all kinds of resources that are available. You might have to do a little searching, but they are there. One of the things that well, let's finish this slide. So private service providers, yes, you can hire privately for home support. If you do that, and again, you can look that up online, or if you find one of the guides is a senior's guide or resource guide online, or just type in home support for your community, wherever that might be. You can hire privately. You can also hire people privately outside of a home support service. I do caution you, though, that there are things to consider, because oftentimes if you're hiring through a home support agency, these people are bonded. They're also covered for WorkSafe by WorkSafe BC, all of these things. If you hire someone not working for an organization, more than likely they're not bonded. They probably aren't covered under WorkSafe BC because that's very expensive for them to do, and they might not have that. So be careful when you're looking at hiring privately. You can look at independent living as well if your loved one is no longer, maybe they're in a home and it's big and it's time to move on. You could look at independent living if they have the resources to look at that, and independent living buildings are available within your community or nearby. Just a word of caution with some of the independent living buildings that you want to probably ask them, private pay ones, you want to ask them what their policy is if your loved one needs more care. Because oftentimes these buildings really don't like home support workers coming in to provide care to their people as they start to become more needy. and require more assistance, and maybe assistive devices and all that sort of stuff. They're not very happy about that. So be cautious. Just a word of caution. The one question you might want to ask is what their policy is. You can go private assisted living and private residential care. All of those certainly have a cost to them. And at any time, if you're paying privately for any of those services, you can still call the health authority and ask for case management to do an assessment and seek that subsidized service, because money does run out. Sometimes we found people who outlived their resources. They thought that they would have loads and loads and loads of resources, money to live on, and they outlived that, and they have, come to us for the subsidy, and no harm in that. But at any time, just be aware that you can access the subsidized service through the health authorities, even though you might be paying privately for any of those services.
All right, I think
we just lost someone there. That's all right. We're still here. So community, public versus private, the type of care required, assistance with housekeeping, transportation, companionship versus personal care. Yeah, you're going to have to do public for that. Private care, if you have preferences of the care recipient with regards to the number of different care providers. Sometimes it's if you pay privately, you have more say over who is coming to your home and how many of who are coming. So if you're through the public system, people will often see many caregivers coming through the home in a period of time, say over a week. There might be quite a number of different care providers coming into the home. Some people don't mind that. For some people, depending on what the situation is, that is extremely overwhelming. So privately, you do have a little more say over the number, usually, of different care providers coming in. Depending on what the financial situation is, the public is subsidized. Private, you would be paying the full amount for whatever the service might be. And the other, if you're hiring privately, as I said just a few moments ago, you have to be very careful. You want to be very careful and screen who is coming in as a private provider. If you're going through an agency, that screening has already taken place. But, and the private agency you can hire, like the home support agency, you can hire privately, and they've done all the work and they oversee their workers. You hire yourself, you have to do all of that, and you might miss something. So it's a little tricky. So just beware of the public versus the private. Private takes a little bit more work in getting the right people. And as Janet said, remember that the publicly funded don't provide any of the stuff there that's listed there. They only provide service for activities of daily living, the hands-on personal care needs, not the instrumental activities, such as housekeeping and transportation, companionship, and all that stuff. Family and friends, these are the personal supports. Family will often say, or friends will often say, oh yeah, I can provide, I'd be happy to help you. And you wonder, well, yeah, okay, but nobody ever does anything. Well, the onus actually rests on you, the caregiver, to tell the people, either your family or your friends, what it is that they can help you with. So you have to decide, what task, what piece of this could I ask someone to do to give me some free time, to give me that little bit of time that I can spend for myself to do whatever it is I want to do. And it might be nothing more than just
sitting in a chair and reading your book for an hour or so. But you have to be the one. So you have to, when they say that, you jump on that. But you think of what it could be that they could do. And there are lots of things, I think, that, you know, someone might be able to come and sit with your loved one for an hour or two. If your loved one likes to go out for a walk and is capable of going out for a walk, but can't go by themselves, maybe just arrange for a friend or a family member to come and take someone out for a walk, or take them to the shopping mall, or do whatever they like to do. But you have to set that up. You are the one who owns this piece. Just what I was saying.
Yeah, just a good way of
That's an
illustrating
excellent
it.
way. It's just an illustration. For those of you who can't see it, it's just a little bunch of circles with ever-expanding circles and the little caregiver with a happy smile in the middle. And when someone says, let me know if there's anything I can do to help, take them up on it. The responsibility falls on you, not on them, to follow up. And the best way to take them up on their offer is to give them a specific task to do. For example, can you stay with Tom while I get groceries every other week? So simple things, but it gives you some time.
Mm-hmm.
Not only can you get your groceries, but you're going out and you're maybe having a cup of tea or a cup of coffee, or you're meeting a friend, or you're doing something.
Mm-hmm.
Maybe you go to the library. Maybe, what?
Sheila. So I think we're close to the end of the formal presentation. So thank you all for joining us. The time just flew by, and I'm glad we didn't have that blip before near the very end. Apologize again for that. And I do hope it's been helpful for you.